Morning, everybody. How are we all? We all awake? Welcome. Someone said no down there. That's too much honesty is a bad thing. So look, you're all very welcome to the ABF conference. It's the third conference we've had since COVID. I'm told we haven't been counting them all, so we've been having ABF conferences for about 20 years. And there's about 200 of you here, so you're all very welcome. It's great to see you. So on your behalf, I'd like to thank Brian and the team, first of all, for organising the conference. These things don't organise themselves. And in particular, to Aoife O'Hay and Lisa for all their really hard work. So well done, colleagues. And just to say what you do and what we do here matters. It may not be absolutely directly connected to patient care, but it's not that far off it. And the information and the decisions that come from that information, the insights, does make a difference in how we tell the story about healthcare, how we secure investment, how we demonstrate what we're doing, and how we improve what we're doing for patients, which is where it needs to, I guess, start and finish. I'm going to cover a relatively small number of topics. I'm going to talk a little bit about an update on ABF, but not too much, because colleagues later on will talk about that. I'm going to talk briefly about the organisation design exercise for healthcare finance that we're engaged in as part of the IFMS Finance Reform Programme. I'm going to briefly talk about NSP 24. And yes, I'll mention pay and staffing. So no hard questions or eggs, please. And I'm going to talk briefly about IFMS and the future. And one, obviously, in my mind, certainly is linked to the other. And then we'll see if we manage to cover all that effectively. So in terms of the ABF update, and just considering ABF and the budget cycle, because obviously it is an important part of the budget cycle, we resumed the use of ABF in 23 to influence budget 24, post-COVID suspension. So most jurisdictions that used ABF obviously suspended during COVID, as did we, and it's being brought back. So that recreates that link between funding and activity, including the service plan that was broken during the pandemic. We talk about a transition adjustment. Brian has carefully explained that to me. You'll hear more about it during the day. But in effect, the transition adjustment for 24 was 85%. So the impact of the assessed, call it relative efficiency or inefficiency of individual hospitals, impacted our budget to about 15%. Okay, transition adjustment 85%, 15% impact. What's going to happen in the future? I'll talk a bit more about that. What's already determined is that the transition rate for budget 25 is likely to be 80%, and 26 is likely to be 75% or more, and we'll talk about it more later. Partly what that means, obviously, is that the timelines for the ABF benchmarking process are really important. Again, colleagues will talk to you about that. We're targeting completion 31st October this year. It's a key deliverable within the finance section of the board's overall strategic scorecard. So it's really important that I know you know this, but it's really important that we keep the coding up to date and that your costing returns are submitted on time. And I'm told most colleagues are managing that and doing their best. So if there's more to go there, please give it attention. I think we've had a year of really great work from the HPO team, Healthcare Pricing Office team, with your support and collaboration around the range of topics. And you'll hear from them today. I won't be able to do them justice, but some of them include the further development of the UAN system, the unique authorization system for commissioning and paying private hospitals, around waiting list action plan, and also soon, as you'll be hearing, for use around public hospitals, including around outpatient department care. There's an update to the coding system. There's an update to the DRG classification system, again, which colleagues will talk to you about during the day, and continued development of specialty costing and patient-level costing, which Mark will talk about. So I'll come back to ABF when I'm covering IFMS in the future, but in short, ABF is here to stay. It is well aligned with policy, including Sláinte Care, and the work of the Ministerial Productivity and Savings Task Force, and it'll be developed further. Now, if I move on to the organisation design exercise for the healthcare, health sector finance function, just a brief update. So firstly, this org design exercise, target operating model exercise, whatever you want to call it, it applies to the wider finance family. So not just the National Finance Division that reports directly to myself in the centre, but also finance colleagues in the CHOs and the hospitals, hospital groups, and the regions, of which they're now part, but also including in that to finance colleagues in the voluntary sector as we roll out IFMS. And that's a key thing. It is very much linked as part of the finance reform programme to the rollout of IFMS. What's its origin? This org design exercise. We gave a commitment, I gave a commitment a number of years ago at an all-staff meeting of finance colleagues from around the sector that we couldn't deal at the time with what people in many cases felt was a kind of a finance function that wasn't fit for purpose. Now, people had different views on that. It wasn't the right size, wasn't the right shape, didn't have enough people in it. But what we said was, in the context of and assuming IFMS was rolled out, along with its standard processes, standard ways of applying those processes, we would look and see what was the right size, shape, location, skill sets, numbers, etc., for just that, for a fit-for-purpose finance function across that wider publicly funded healthcare system. Okay, and as I said, really important, it was in the context of IFMS and is in the context of IFMS. So that exercise is being carried out for us at the moment by KPMG. It's been underway for some time. It has been, and they have been engaging with senior finance colleagues at national and regional level, i.e. CHO and hospital group colleagues, around both the as-is and the challenges. You know, what are the pain points related to any likely to be? Because we've challenged them being KPMG, not to negotiate with us, but to facilitate, to apply good practice, best practice, and benchmarks where they're available, which is an imprecise science, as we know, to say, what should a finance function look like? As I said, what skill sets, what should be located where, what numbers, etc., etc. It's very much linked in to the development of the health regions and the revised centre process that Liam is leading on, which you'll hear about later. To manage expectations, it's not a magic bullet, okay? It's not a job evaluation exercise. It doesn't allow us to avoid the reality of scarce investment funds. Therefore, the reality of the need to prioritise those funds for patient care and the fact that any investment, if it's evidence-based through the exercise, will be secured through the normal cycle, i.e. through a number of annual estimates processes, most likely over a number of years. Also, to manage expectations, it'll challenge us. There may be things we don't want to hear in terms of how we should organise and structure the finance function across the public healthcare system. We may need to do different things. Certain workloads may need to move, okay, because it is in the context of IFMS, which means the context of broadening and expanding shared services, okay? But that was always going to be the case. That was part of the original commitment, okay? What it should provide us with is an evidence-informed view of the current finance organisation design and whether it's fit for purpose or not. And I think fundamentally, overall, while it works well and people in it work well, are able, dedicated and hardworking, the system and structure isn't overall fit for purpose. So it's timely to look at it. So in summary, it'll provide a stocktake and a roadmap that we can pursue over a number of years as we roll out and realise the benefits of IFMS, which, as I said, involves that expansion of shared services. So I expect we'll have a draft report from KPMG in the next month or so, and that's something we can engage on. So more to come on that one. If we move on then to the third topic, colleagues, which is delivering on NSP, National Service Plan 24. In my view, it starts obviously and finishes with patients, service users and their families. And I know you know that. So it is about providing them with quality services that they value. And to me, quality and value can and should be used interchangeably. Their characteristics involve safe care, do no harm, effective care, that's evidence-based care, and only if it's likely to benefit the patient. It's not about what benefits the provider or the staff. Patient-centred care, so it takes account of the patient preferences and their values. Efficient care avoids waste, including waste of time. And waste of time and skill sets and knowledge is probably one of our biggest wastes. We'll talk more about waste later on. Timely care, so reduces waits and harmful delays, and equitable care. Quality consistent regardless of socioeconomic status, gender, geographic location. And when Sarah talks to us later about population-based resource allocation, that's a tool which should assist, particularly with that last one. So I think we all know, and it's generally accepted, including by government, that the health and social care services in this country need continued, very substantial additional investment if we are to deliver on our potential of high-quality services providing value for the people of the country. But I would argue, you may or may not agree, we have to acknowledge as well that we have had strong support and very significant investment from government over recent years. There is plenty of evidence that government intends to continue to invest, but we need to make it easier for those making those decisions around key investments. Again, you know this, but useful to remind ourselves, we compete for investment with other valuable public services, many of which are key to determining people's health status, just like the health service is, and are less complex and less difficult to understand and navigate and tell the story of than healthcare. We also need, I suggest, colleagues, to challenge ourselves. Needing more investment, which is plainly the case, does not of itself imply that we are actually doing the best we can with the resources we have today. It's not one or the other. They need to be, whether you're doing the best with what you have today needs to be separately demonstrated while you also pursue appropriately the case for investment. So that doing the best you can is a never-ending journey, and it should be never-ending. It is about continuous improvement. That continuous improvement often characterized by many small steps with the odd innovative leap. So it isn't all about the brave new system and, when I get older, I'll get better, or, the grass over there. It's about today and what we can do today, every day, working together to improve processes. So it's all focused and needs to be focused on what adds value from the perspective of the service user or patient. If it doesn't add value for them, if it's not something they'd be happy to be paying for, it's not adding value. And that means removing all forms of waste from our processes. Now, people sometimes say to me, don't put the word waste down. We can't admit that there's any waste. Now, there isn't a process on this planet that doesn't have some level of waste. There isn't a process on the planet that can't be improved to some extent, or almost none, okay? And it doesn't matter how long the period of time it is to make those improvements and get rid of all the waste, or as much as you can. The issue is you have to pursue it as a structured, continuous improvement exercise over time. So waste of time, waste of skills, waste of knowledge, time, skills, and knowledge of both patients and staff and service users and their families. So we also have to, though, as well as that, we also have to, post-COVID, and again, like every other public healthcare jurisdiction, we also have to return to a more normal financial management approach where we operate within budget. Now, in practical terms, that means returning to a situation where we operate within the funding level made available to us with minimal reliance on supplementary funding, and then primarily for post-service plan decisions, technical adjustments, and genuinely unexpected and unpredictable occurrences. And that is a message I would give to myself, my EMT, my CEO, and our funders, just as much as we give to the people who are spending the money on the ground. It is a two-way thing. It's not all about how well we manage the resource. Part of it is. It's also about whether the target and the value or the fund that was set was the right one in the first place. The data, the insights that we talk about here help us understand and tell the story of why does it cost, what it costs, what should be funded, and what have we still left to do in improvement, even though you have to fund it today at what it costs today. So that's a two-way street, and it's not simply talking to providers saying you must do better. We must do better as providers, but the funders have a job to do as well. So that to me is the context for NSP 24. It should help us make some sense of the various priorities and challenges within SAME, noting that many of these will be continuing to be worked on over a number of years. Now, Aoife, how am I doing on time? 5 minutes left. Oh, good. Grand. She's the boss. Okay, so pay in numbers, and again, without being glib about it, but Aoife told me I had to hurry up. So we know the current situation is not sustainable. It's not appropriate. It's not what anybody wants, including not what the CEO wants. In fairness, not what the minister wants. So we know we need a decision on pay in numbers soon. We know the current pause and derogations isn't effective. We know we need to give control back to the regions and let the regions and the RDOs give that control appropriately down through the system. Okay, and we've known that for some time, and we've been waiting for some time for a decision on that. So it continues to be our aim to get that decision. My sense is we can see the end in sight in that, but it's a couple of weeks yet. So, but fundamentally, we know it's not currently working. Now, we have to then be careful. We have to be careful what we wish for. So When that decision is made, it will draw a line in the sand. It will say at some date, all of the posts in all the grades, on all the cost centres, wherever they landed, that is what is going to be funded. Any vacancy that exists before that will not be able to be filled unless headroom can be made by prioritising within that funding level. Okay? And that means some services will have to walk back before they can walk forward. So the benefit will be the REOs and those below them closer to the services will make those decisions. They will prioritise based on the risks that they see. What they will have to do, and this is a nuanced change, but an important change, the CEO is very clear. It will be within a WTE control limit, a number, and a pay budget. It won't be sufficient to have one or the other. So some people may have the WTE, but not enough budget. Others may feel they have more pay budget than the WTE limit. Those two will have to be reconciled. So the control piece is going to absolutely be about the WTE number and the pay budget and people sustainably managing that. So that'll get us to discussion about productivity and savings, the Ministerial Task Force, which the CEO is joint chair of, and some of us are members of. The savings part of it, the big things you'll see, 250 million agency savings, right? That's a third volume reduction in all of the agency. That is not going to go away. It will be moderated. It won't be 12/12ths of that 250 million. It may be 9, it may be 8, depending on when the actual decision comes, because we've held off on giving out that target to people in the knowledge that until they can make their own decisions about what posts they fill and don't fill, it's just not appropriate to manage the risk. But it is known that you can't deliver a third volume reduction without going into the clinical areas. And the key message for people would be, and we've given this to the REOs as well, the key message is people need to engage with that and figure out how they can deliver as much of that as possible. And as I would say, if you can't deliver 99% of it, you say how you are delivering what you can deliver. We'll argue about the 99%. Don't start from the end of the stairs saying, not going up there. Can't even have a go at that. So that's not going away. Agency conversion is there. Agency conversion is important. In financial management terms, it's a red herring against that 250 million target. So if you're looking at which to focus on, that's the one you focus on. And the key is doing what some of you in provider land do really well, which is knowing exactly why we have the agency we have. Not everyone knows that. Non-pay saving strategy, we've mentioned that. We've given people a little bit of respite. We've been able to live to the outturn 23 level with a couple of exceptions in terms of acute hospitals. And productivity, I won't be doing it justice, but effectively, as you all know, and as we're here to talk about today, really, given the data and the insights that ABF allows us to gather, that is about better managing demand, firstly, when that's appropriate. It's about better balancing that demand with available capacity and then driving more activity safely to the same or less staff hours or same or less staff costs, because skill mix is an important piece of efficiency and productivity. So the ABF approach, including the benchmarking data, can assist with this. There'll be lots of commentary on our productivity. I think we have to be open and engaging with that commentary. We may not like what people say. If we engage with it, we can moderate it. We can help assist people. The HPO played a very good role working with colleagues in the department recently on what's referred to as the IGEES report that was issued recently about hospital productivity. Again, we may not like everything it says, but we need to be up for the challenge of addressing the points, the questions it raises. And in all of that context, transition adjustments, they're going to continue and they're going to continue to fall. Finally now, in terms of, sorry, it says stop. Okay, but I'm the CEO today, so. Okay, so IFMS update in the future. So look, in shorthand, the IFMS go live in the East was very, very difficult. The bucket of lessons overflowed a number of times. People closer to it than me are the people you should talk to if you're getting ready to go for the next two rollouts, which is IG2 and IG3, which we're working on for the 1st of April next year and the 1st of July. So, too many lessons to be learned, things we did wrong, things we have to make sure we don't do wrong again. And the fundamental covenant was, when we agreed with the steering group, that we would proceed and we would seek to accelerate, was we have to have a fit-for-purpose system. So, what does that look like? Well, We can now show people the system live. We've come through 6 weeks of fit validation workshops, huge engagement. And again, if you were involved in that, thank you very much. They're all about figuring what are the gaps. Where you hear the word gap, that's where IFMS will seek to make a change to IFMS. And where you hear the word change impact, that's code for the local service will need to change its process. Okay, so it's really, really important that we're clear on that. But as I said, we can show people the live system, couldn't do that a year ago. Two of the big areas that we let's just say, had difficulties with, if we weren't on camera, I might call it something else, were the NDC, National Distribution Centre, and Capital. They're national, so once we've sorted them, and we have broadly sorted them, you don't have to do them again. Vendor invoice management, another massive area of difficulty. We now know an awful lot more about that, And if we learn those lessons, that can work really well. So the engagement with people so far is really important. We've changed the way we're going to roll out. We're doing it by regions. We're setting up regional implementation teams, regional working groups led by the Oreos or their nominees. And we've added an extra layer of support in terms of dedicated teams from the external provider, IBM, as well as the regional team. So there's 6 of each of those teams, 1 for each region, dedicated purely for that region. So look, I believe we will do a really good job of rolling out to the rest of the statutory system. So that'll be 100% of the statutory system by 1st of July, all going well next year. And then we do the voluntaries thereafterwards. So if we talk for a second about the future, so our aim is to improve what we can, including with the help of ABF, data and the HPO, in advance of IFMS, and then enabled by IFMS when it's available, to use it, to link it to HR, to link it to other activity systems, to do what we all really know we need to do, which is tell the story of why things cost what they cost better, and improve the service so that we could get more patients safely through those services for the same or less money. So what will we see in that future? Don't have a crystal ball. We will see a 5-day close. So we will see 5-day closing report. We'll see it in the IG1 areas, and we'll see it this year. And that'll be in the coming months, not at the end of the year. We will develop a rich agency billing system, which we'll eventually integrate into IFMS. And in some of these cases, such as this one, we're stealing good ideas from people who have done these things already and introduced systems, controls, and processes. So we will introduce a rich agency billing system, which will allow us to get agency hour data directly from the bigger suppliers and give it back to the hospitals. Some of you get it already, some of you don't. The key thing is we'll be seeking to put a reason code on that so we know what the reason is for the agency, and we can report on that. We will, this year and next year, start reporting differently on acute hospital costs. Nationally, acute hospitals appear to us as one single big cost centre. That doesn't help us tell the story of costs and acutes. We have to progressively move towards telling the story in terms of, are there pressures in outpatients? Is it on the ED floor? Is it in the scheduled care side of day cases or elective inpatients? Or is it in the other areas, including externs? So the true north here, and this isn't a this year one necessarily, is progressively as we roll out IFMS, the challenge to the HPO and colleagues is how much of the annual exercise that is the ABF process, the specialty costing, the benchmarking, how much of that can be done on a quarterly basis or a monthly basis, and how much of the interventions that are currently manual to do that can actually be automated. So that is the ultimate goal. And like any true north, it could take you a number of years to get there. The importance isn't actually when you get there, it's the improvements you make along the way. So those things are coming. If we look at pay numbers starting this year, we will start making progress towards funded complements. As I said, once that line in the sand is drawn, it's unfortunate, like any line or border, it causes border issues either side of it. It will simplify the exercise of figuring out what posts, as I said, are funded, and then attaching positions to those, and attach funding to positions and employees to positions. And that is something we will make some progress on this year. I don't expect it to be fully complete. Separate commissioners, one of my colleagues there depressed me on the way in about the volume of separate commissioners and all that kind of keeping track of who's ordering what posts and in what way they're doing it. Now, that's not something we'll sort in a day. It is something, learning the lessons from some of you who've made good strides on that, we at the centre are going to have to improve. Now, a bit like the ship's captain who says his job as captaining ships would be great if it wasn't for all the water. any notion that there's going to be less separate commissioners or that's the solution is probably not realistic. That's not going to happen. So we are going to have to find better ways to manage the volume of traffic and manage how the centre interacts and how it commissions services and how clear it is, or sometimes maybe isn't, about what it's commissioning. The IFMS 10-day quarterly bottom-up forecast, that will come as part of IFMS. Okay, so as well as the 5-day close, we're working towards a 10-day quarterly bottom-up forecast. Price and volume reporting for both non-pay, which is dependent on material codes being used, material groups, and on the pay side, which is back to that attaching positions to employees to positions and funding to positions. That's price volume by hour. That's the aim with IFMS, linking with the HR system, NISRP, NISRP. People have heard of that. I mentioned streamlining the ABF process. Transition adjustment, that will continue to fall. It'll fall towards 50%. I don't know where it'll stop. I don't know how quickly it'll get there. Strong view is its fall will be accelerating, not decelerating. The desire and the push will be to accelerate it falling. And population-based resource allocation, that will progressively seek to more fairly allocate the available resource based on population needs. Key point, and Sarah will talk about this later, it's a resource allocation method to allocate down to a population, if make decisions about the population, to remove inequalities. It's not a payment method. You'll still have to have a way to pay providers, either using budget, which puts most of the risk financially on the provider, or using cost reimbursement, which puts most of the risk, all the risk, on the funder. Or something like ABF, which kind of sits in the middle in terms of balancing the risk between funder and provider. So the two will peacefully coexist. You can't have one without the other. Where it makes sense to pay by activity, and it will in certain cases, methods like ABF will be required, as well as population-based resource allocation, which will decide a funding level at a higher level nationally. So in conclusion, apologies for going over the time. What did we cover? ABF, look, it's here to stay. It's well aligned with policy, and it'll be developed over the coming years, with the adjustment likely to be accelerated and to keep falling. The org design exercise, not a magic bullet, but will give us a stock take and a roadmap, and we should have a report in the next month. The NSP, it's always about challenges and opportunities, but it always has to be about what's in the best interest of the patients. That's the start and the end of it generally. And are we doing the best of what we have? And then I think the future around IFMS is bright. So look, to remind you again, what you do is valued. What you do directly or indirectly makes a difference to patients. It really does. Telling the story now is not quite as important as doing the necessary, but it's becoming very much more important. And I and the CEO have faith and confidence in what you do and in what's happening here through the overall ABF process. So with that, I'll shut up. I hope you enjoy the rest of the day. Thanks very much.